Hello and welcome to the Complete Physio podcast. In this episode, we're with Mr. Daniel Howes, who is a very experienced strength and conditioning coach. And I've been working with Dan for around 10 years. And we're going to be talking about occlusion training, which is also known as blood flow restriction training. So there'd be lots of people out there that don't know what this is, Dan. So let's just start with that. Yeah. Can you give us a bit of an intro about occlusion training, sort of how it started and how we've come to talk about it?
Yeah, so occlusion training in its simplest of terms is where we restrict blood flow to a muscle. So all of us in everyday life need blood flow to our muscles to supply us with oxygen to do activity. And there are some original studies that came out of the sort of Japanese culture from, it's often referred to as katsu training, where an individual did some self-experiments to see if he could accelerate his rehabilitation from injuries based on restricting that blood flow, so occluding that blood flow. And athletes or people that go on and undergo surgery have occlusion to stop blood flow to limbs as they're being operated on, as we know. So that form of training has been developed over time, and there's been really good efficacy to show that you can alter the physiology in the body. You can have some really positive changes by using this method of training, where you, for a transient short period of time, occlude a muscle, potentially work that muscle and create a specific adaptation. And actually it's an efficient modality of training. So we see it in the rehab space because we can get more adaptive change out of a muscle than potentially the body can allow at that point of rehab, because there's a deconditioning in that muscle. And so we can artificially create an environment that allows the muscle to grow based on the physiology that we alter.
It sounds like it's cheating.
It does sound like it's cheating. It does. But if you look at the body responds irrespective of, as a strength conditioning coach, I'm looking at stress and I'm looking at response. And so if I'm going to train somebody to be stronger, I need to elicit a certain physiological stimulus to create that adaptation. So in the fully fit individual, if I need to get muscle on them, then I need to create a lot of tension in the muscle. I need to create a lot of acidosis in the muscle, so I need to change the pH of that muscle. And I need to do that, or I do that through high reps and a moderate load, maybe 70% of a 1RM. But when we've got injured athletes, that's compromised. We don't have that stimulus available to us early in the rehab process. And we can do bodyweight stuff. Well, actually, occlusion or BFR training allows us to capitalize on the fact that we can function with, say, body weight or low load, occlude a muscle and stop the oxygen getting into the muscle, which then means that we're actually getting the similar response we would get as we would do at, say, 70% 1RM, just by using 10 to 20% of 1RM, or even body weight.
We, in the physio clinic, obviously, we see lots of patients that can't do heavy load because they're injured, they've broken something, or they've had an operation. So we've been using it for a while for those clients, because it's allowed us to get some strength gains, but without putting full load, which could damage that healing tissue. So do you just want to go into a little bit more detail around where you put it and how you use it? Just to give us a bit more of an idea.
So traditionally you could look to use special pumps as such. Classically the comparison would be like a blood pressure cuff. We all know that feeling when we have a blood pressure cuff on our arm and it's pumped up, and that's essentially occluding blood flow. That's testing the point at which blood flow is occluded, and then we let go a little bit of air out of that and we assess the blood pressure based on flow back into a muscle. Occlusion is basically that first part where we pump it up and we restrict blood flow to the muscle. And the two key places that we use it in terms of athletic or even the clinic space with clients is we have to be proximally occluded. So for the upper body, we're doing that right up in the armpit at the top of the bicep. And for the lower body, we're doing that right up in the inguinal crease, basically, as proximal as we can get on the leg. And we can do bilateral at the same time. What we can't do is occlude all four limbs at the same time.
You might collapse.
Yes, exactly. But basically, when you can use that garments, like classic blood pressure cuff type garments, or as HYTRO, a company that I'm working for, they're solving that problem of creating a wearable. So embeddable straps within a wearable short garment or a t-shirt garment that just make the ease of application far quicker and simpler than having a bit of technology. That's where the world has gone with blood pressure cuffs now, is technologically driven, and they're not exactly fail-safe.
So you need a device to do this, obviously. We would not encourage people to get their partner's tights
No.
and put them around their arm, although some people do that, and
Yes,
there are
yeah.
actually bands out there. But certainly from a physio point of view, we have to know roughly what pressures we're putting in, because obviously one thing people will be thinking at home is, well, is that not dangerous? Do you want to just talk us through any sort of safety issues or where we are on that argument?
We'll just go back a step first to just understand the physiology, to understand the potential perceived risk. You know, if we're doing, say, 4 sets of 10 in a gym, the reason that we're creating hypertrophy there is we've got a lot of strain going on in the muscle. But the difference with that modality is we need high load, and we end up desaturating. That's where oxygen goes out of a muscle and creates this acidosis in the muscle. And then we recover. We have 60 to 90
But that
seconds.
environment we need, don't we?
Yes,
to get
we need
the
that.
adaptation.
But we can't create that in an injured or an individual that's maybe never even done weights before and they've got a rehab. So when you occlude a muscle, you're not letting oxygen back in. So a classic scheme would be 30 reps, 30 seconds off, 15 reps, 30 seconds off, 15 reps, 30 seconds off, and then the last set of 15 reps. It's a very high volume modality, but it's very low load. You could do it at body weight. Because you're occluded for the whole period of time, you're just getting more and more anaerobic and more acidic in that environment. And that drives a really big sort of anabolic response that's natural with weight training, but from a lot lower load. Now, okay, that's where we think, well, that could be quite dangerous. But if we think about the risks, there's obvious risks where people should not do this training. And those are going to be vascular disease background or history of those in your family or as an individual, neuropathy, so neural issues within your case history. And those would be sort of the main two that come up. There's going to be other ones that you should seek advice.
Yeah, and generally this is going to be done on people that are fit and well.
Yeah.
You know.
And I think when people hear the word occluded, they think like a tap. They think it's stopped.
Yeah.
And we're not fully occluding. No. Like that would be really, really, really high pressures. Yeah. Really, really restricted.
So there is some oxygen going there.
Yeah,
there is blood flow
we
going
talk
in
about
and
a
out.
percentage. So we say, okay, well maybe we're getting about 80% or 70% of what we call LOP, which is limb occlusion pressure. So it's 70% of what it would take to occlude fully.
Yeah.
And that's important to know in some cases, but it's also difficult to regulate. And so HYTRO as a company who are a wearable have done a lot of research. They're evidence-based. They've demonstrated safety and efficacy and independent use for their garments using a BFR training. Because their garments don't go up to above 220 millimeters of mercury, that would be the pressure. And that still would be sub-occlusive in some respects for a lot of people.
Yeah.
So there's a real good safety net with the fact that the upper limits are within safe limits.
Yeah.
And then there's education. Like education with your clients is really important. You know, are you educating them as to the correct methodology that they should be using, the correct way to use them? Because just like a Normatec boot or any other, you know, Graston type of modality, if it's overused in a negligent way, it's going to have ramifications. So education is really, really key. But there's the safety embedded within the product because of the upper limits. And the same with a lot of other garments, whether they're pumps, they only go up to a certain limit. Or the ability to quick release from them allow you to create an affordance to get out of jail.
I mean, in the clinic we had the Delphi machine, which I think was over £2,000. So we could use it with patients in the clinic, but they had to come in. And I think what HYTRO's done is given us a solution where patients can sort of learn it in the clinic, but then take it into their own gym and be able to use it, because it is quite easy to use, isn't it?
Yeah.
And it's affordable.
Yeah.
It's not.
If we go back to why HYTRO developed what they've developed, every good product is there to solve a problem, right? And so my history goes back to working just after we met with England Sevens, and at that point, blood flow restriction for rehab was being used to really good effect. But we were let down by the garments, we were let down by the fact that the pumps themselves for the pumps were breaking or splitting. Also, exercise with tubes and wires is really difficult, and the Delphi unit, as you know, is cumbersome because you have to plug it in. There's a high level of regulation, but there's a low level of practicality to that work. In the athletic space, and even with your client space, time is really crucial. And also your trust and your integrity is really crucial as a practitioner and clinician. And so HYTRO the actual founder, Warren, was a nutritionist at England Sevens, and he watched us. And sometimes somebody without a bias sees a problem you never saw.
Yeah.
And he's like, well, why is this so cumbersome? And he went, this should be embedded or wearable. And he went down that route, and he created this product with an evidence backing to make it a product that was evidence-based, practical in nature, and scalable to large numbers. And that's really important for sport, because people see occlusion or BFR training, and we'll get onto this later, as a rehab modality only, but there is a huge opportunity for it.
And Warren, the guy who founded it, he's got a PhD, hasn't he?
Yes,
And he's very focused around the research, and I think there's lots going on with clubs at the moment, isn't there, around using the HYTRO device and trying to get further evidence for it. So what I want to go on to now, because certainly when I was using it a lot at British Athletics and a few different English Institute of Sport, we were generally using it for rehab, which we will talk about. But do you just want to go through the different options that you have and when it could be used with your athletes or with your patients?
100%. I always talk about opportunities, right? As a practitioner working in performance sport, the first thing I'm realizing is that all we're doing is problem solving. All we're looking to do is probably all work to very similar outcomes, but with very different constraints along the way. And so what problems are we trying to solve? Therefore, we need to know what opportunities a modality like blood flow restriction, irrespective of what tool you use to elicit it, can afford us. And so we go down this rehab route quite traditionally because it's the most used modality or most frequent. However, there are numerous research papers out there that are showing the benefits in other areas. And those other two areas are prior to exercise and post-exercise. So if I look at the three areas of opportunity for blood flow restriction training, it's using BFR for exercise, so in preparation for subsequent exercise. An example being using it prior to football training,
like as a pre-activation
or a pain relieving or pain management tool. So we know that we can have a positive impact on pain modulation by using it prior to exercise, so that the subsequent exercise is enabled as such. So in clinic space, it might be 5 minutes of BFR passive work to create a pain modulation that drops in order for you to load them through range that you couldn't previously do, which is really important, right? The next one is as exercise, so blood flow restriction used as exercise, and that's the most commonly used modality, which is this 30-15-15-15 model to elicit mostly adaptive changes or strength changes with low load by comparison to the traditional methods. And then the last one is BFR after exercise.
So your recovery type.
And there's 10 to 12 years of research in this space now that shows that if you can use BFR quite soon after exercise, there's benefits to perception of soreness in the 24 and mostly the 48-hour mark after.
So you might feel that you can get back to sport quicker because you feel more ready in your muscles.
100%. And actually the biomarkers that have been shown in some papers show that creatine kinase, which is the associated marker to muscle damage, has been dropped rapidly as well. So it's not just a perceptual, there's a biochemistry blood marker change there. We're also seeing that you can restore muscle function. So there's been EMG studies that show at the 48-hour mark that muscle activation has been enhanced or restored. So we're never looking after exercise to enhance performance. We're looking to get back to our performance. And so it's an accelerative process by using BFR by comparison to doing nothing.
So as you said, that there looks like there's lots of opportunities
really is,
in professional sport, particularly where you're trying to get somebody ready and you're then trying to get them to recover as quickly as possible.
But even in the we could call them the weekend warrior, the client in the clinician space, is that you've got somebody that maybe you're doing maintenance work with, and they're still active and they're doing work in their sport or weekend activities. You've got a tool here, especially with HYTRO, which is a wearable. You've got a bit of kit in your kit gym bag, really, that can be used to solve a number of problems depending on the context of that person's world. So you may have the same client who 1 week has done a bit too much training and feels really sore. And so you could use it in a recovery sense for that. But that same person could be traveling internationally on business and not have access to a gym for a week. And so they could use this to replace their traditional strength training.
So instead of going to a gym to try and get some muscle bulk, they could be in their hotel room with the BFR working at a lower level. So they could just be working body weight, so they don't need any equipment. and actually they're getting the same strength gains.
Yeah,
it does sound like a cheat, but a pretty good cheat.
I would say that it's at least maintaining at that level, which is better than the problem in the first place, which is I can't get to a gym. That's more what I was getting at, is that you got something that can go in your bag. You've got something that is, there's no excuse for not doing it because it's so practical and
There's
scalable.
always excuses.
I know. But for everyone else. And so but in the sports space, in the athletic space, especially the team sports, who have different problems each week to solve, because a 3-day turnaround for football versus a 7-day is a very different set of problems, and recovery becomes really important all of a sudden. And even the preparation for certain training sessions that week, maybe that we've got one key training session and we need this key player on the field, and suddenly BFR becomes a solution prior in preparation again.
So really what HYTRO has done is it's taken something in elite sport, it's almost that trickle-down effect into the general pop, and it's given a solution that maybe more people could start using this when it's safe to do so.
100%.
Is it something that needs to be supervised by a medical professional or a physio, or what's the thoughts around that?
Yeah, the first thing is that there's a needs analysis or client analysis of, are there contraindications? And so whoever is working with that individual should be going through that process of understanding, are there any contraindications to use here? And those are readily available as pro formas that people can reference on the HYTRO website. That's the first step. The second step is education. Whoever you're working with, if it's a modality they've never used before, they're going to need to be educated as to the why behind it, because it's quite a tough modality. It's not a comfortable feeling to start with, because you're basically making your muscles really, really anaerobic. You're stopping energy getting there, and you're asking them to work.
And if you're not used to that...
100%. Like anything, there'll be a tolerance to something. So to start with, the education and the gradual, I guess, trust of the method is really important. However, we know that it's safe to use independently, subject to it being well educated to the client, because anybody can go off and do something the wrong way. And that's where independent use for any modality goes wrong, is that the lack of education. So it's safe to use in that way. And the whole point around this value within HYTRO's vision of being scalable is not necessarily scalable between general population and sport. It's that in sport it can be used across all the athletes to help work and overcome their specific individual problems, as opposed to just being something that the 4 injured players are using out of a 40-man squad. And so then it suddenly becomes very powerful as a modality, and exciting times.
I mean, certainly from a physiotherapy point of view, I'm trying to think of the clients. I'll give you a few examples. Recently, I've used it as a warm-up for a patient with a patella tendon problem, and we were able to get their pain scores down significantly in their warm-up in preparation for them to do their heavy loading. That worked really well. And actually, I had a sprinter that ended up using it before they trained, which at first we were slightly concerned about, but it was fine. Post ACL rupture, we've used it loads. Meniscal repairs as well, where you don't want to put too much load through the joint, and Achilles ruptures is probably the area I've used it the most, once the surgeon is comfortable with us using it as a modality. And it's meant that we've been able to get that bulk back, I think, quicker. But also the other thing that you've talked about a bit, but we can go on to, is that if you are working at a lower load, you recover quicker, so you can load more regularly.
The frequency and density of it becomes more useful, because there's less of a cost. When we look at working at high intensity, there's a huge CNS drive, and there's a huge element of potential what we call central fatigue. And this is a little bit more of a peripheral type of stimulus and adaptation, because you're working at the fatigue is happening locally at the muscle. And as a result, that you do recover, and also the modality itself, where you're creating a restriction of blood flow, and then as we occlude, we've got this what we call this reperfusion of oxygen. That's this surge of oxygenated blood back into a muscle, and that seems to have a much bigger effect on recovery than just normal systemic work. That where blood flow is not altered, and you're just promoting normal blood flow. So that's really, really exciting. But the one thing with rehab is, Bill Knowles, who you'll know, I heard speak recently, and in the rehab process, irrespective of modality, if we can promote early healing and adaptive change, then we're not trying to accelerate the time back to performance. We're just giving ourselves a bigger preparation time, which is a really big advantage. And that's the big thing with the occlusion training. Is it's going to be brought in early in the rehab process to create hypertrophic change, turn around the atrophy that you've got, get symmetry in muscle bulk, etc. Get reduce apprehension and build confidence, so that the weight training can happen earlier. Or when it does, at the same time point it normally happened, you can already tolerate more load. And which buys you more time at the end. So that's where people think, oh, do I just use it for the whole rehab process? Probably not. There's got to be a moment when traditional weight training at 60, 70, 80% plus becomes the stimulus you need at that point.
Because there's got to be a reason to do it. We know strength training works. So if you can load at 60, 70%, do 3 sets of 12 or whatever, and get some metabolic fatigue, then you're going to grow muscle, aren't you?
But I'll say a great example, case in point, with clients that we work with are some football clubs. Some football clubs don't traditionally have weight training as a non-negotiable in their training schedule. And actually HYTRO has been used to good effect to kind of negotiate with the athlete that actually let's use this in a bit of a different method. Let's use it with a 10 or 12 rep scheme, and let's use it intermittently. But let's occlude you with a lower load so that we can get some neural innovation, we can get some strength changes, because it's higher load than body weight. But there's less of a muscle damage effect, and there's less of a soreness effect. So it's this nice middle ground trade-off.
So they're more comfortable, because a lot of people don't like that feeling that I've just,
or the feeling of I've just done a heavy weight session and I feel very fatigued. I'm lagging leading into the game. And with fixture density in a lot of sports becoming higher now, actually the first thing to go is your non-technical work, like a weight session, I imagine.
Absolutely.
So that's been really, really good, because it's so quick and easy to wear around the gym and strap into, occlude for 4 sets of back squat, go over and do some upper body, and then maybe occlude for some lower body stuff like hamstrings. And we've got a good stress and stimulus, we've got potential for an adaptive change, but we've done it with potentially less soreness and cost. So it's a really smart way that it's getting used.
Do you want to just talk briefly before, obviously our cameraman has volunteered that he's going to do the HYTRO occlusion training with us. But do you want to just go through the general routine that you use? Because I know there's sort of 2 options, isn't there? That you can do what you like, obviously, but what are the general
I think
programs?
I'd say you probably wouldn't encourage to do what you like, but more to do but to put it into.
Well, as long as they're clinically reasoned. But
100%. There's a clear rationale and reason. What you don't want to be doing is wearing them all day, every day. That's the thing. So, what we want to educate people on is we've got a repetition-based type of protocol, because we want to create muscular changes, strength changes, or we've got some passive modalities which have a different purpose. Now, so if we think about...
Well, let's go through those.
So the repetition-based modalities would be, classically, the research has shown that to good effect, if we use 30 reps, and we'll take body weight with shorts on, strapped in, occluded.
Both legs?
Both legs at the same time, if able.
To start with, particularly.
So we'll go 30 reps of body weight, and then we'll have 30 seconds off, but you stay occluded. Right?
So you keep the pressure on in the rest period.
And you don't change it. So what we're seeing is that we've done 30 reps, our oxygen saturation has dropped, and where we would normally do a rest period in a set of 30 reps, we end up resaturating the muscle. But we're not allowing that, because we're keeping it strapped on. We do another 15 reps and we go down, more desaturation, more fatigue, and so on and so forth. The reason it's 30 to start with is almost a fatiguing set. And that's why then we only have 15 for 3 sets. And all of it is occluded, so 30, 15, 15, 15, interspersed with 30 seconds rest, and then unocclude. And that could be used for a back squat, for example, a hamstring curl or bridge, calf raises. And that in itself would be a very good and generic way to load the lower body for a lower body injury that's coming back.
And you've said it already, but there is good evidence. If people Google it, they will find evidence supporting exactly that routine, won't they, for muscle growth?
Yeah, and a lot of the papers, the academic papers, focus in that way on that regime, because it's been the one that's showed the most desaturation of oxygen, most fatigue. It's also...
And it's been shown to be safe in these studies.
And when you occlude and have this continual fatigue happening in the muscle, you get also preferential fiber recruitment. So the more fatigued you get, or less oxygen there is in a muscle, the more that type 2 fiber is going to work, because they need less of it, and they've got more fast sort of ATP supply. So that's really useful as well, because muscle bulk happens with fast twitch fibers, not slow oxidative fibers. So when you're doing rehab without BFR, the chances are, because it's so low load, you're only creating hypertrophic change in slow oxidative fibers, which don't get that big. So lots of benefits, again, to using this modality. So that would be a repetition-based scheme. And because you're coupling that with contraction, that's going to create more of an adaptive change that is going to stimulate muscle growth as well. Right? If we use a passive modality, and a passive modality would be up to three, ideally, optimal, 5-minute occluded sets. You're occluded. We could just be sat here now, strapped in, really tight. Relaxing, chatting, recovering as such, putting the straps on, 5 minutes, and in that time they'll be slowly desaturating the muscle. So
I know many athletes that will want to be using this passive technique for recovery.
So a lot slower in terms of desaturation, which is why we need the 5-minute period. Then we'll unocclude, and we can go to 3 minutes recovery. And some of the research has done 3 to 5 minutes, but we're advising 3 is fine. 3 minutes upon which you resaturate a muscle, muscle oxygenation goes up. And then you repeat that cycle optimally 3 times. And because you're not coupling that with a stimulus of contraction of a muscle, you're getting a slightly different response. You're not creating any soreness in the muscle, but you're not getting a hypertrophy change. You're creating more of a lactic response in the blood, and more of a sort of anabolic acute growth hormone surge, and you're doing it without the contraction. So that's shown to be useful for recovery as such, but also pain, like reducing pain, and we're seeing that
as in almost like a DOMS type
so we know that
DOMS
is and pain itself, both those things are influenced on the sort of nociceptor, how much that's being activated. So there seems to be an effect on those that suppresses the sensitivity of them and obviously reduces pain. And the same goes for perception of effort actually as well. You can use this modality pre-exercise, and it'll, for the same given cost, it seems to reduce your perception of that effort
during the actual
so there's some really cool stuff going on there, and we should probably put some links and footnotes to some papers and things like that.
Really
because
good,
there's a ton of great stuff there. But that passive modality we're seeing football clubs use on buses on the way home. We're seeing people who've got ACL surgery pending before they go into surgery to retain muscle mass. Now they're not going to get bigger because they're not creating any strain. But they can retain muscle mass by creating an anaerobic environment that is just like they trained to maintain that muscle mass. So some really cool opportunities in those two modalities, and they place obviously with a repetition based needs activity and conscious effort, whereas the other one needs a passive buy-in as such, and where do we want to place this in a given week, or in the way that we operate in our club environment or clinic space.
Brilliant. Well, I think we've covered most things there, Dan. So what we're going to do now is we're going to do a demo of the HYTRO wearable.
That's it.